Hello and welcome to this webinar that FHI 360 has the pleasure of hosting in partnership with Africa CDC, a first in a series of 5 bi-weekly webinars where global experts will have conversations around critical aspects of COVID-19 response. From their vast experience, they will share with us best practices and isolate those adaptations that are needed to optimize outcome in resource-constrained settings. If you have questions for the panel about today's discussion, please contact us on Twitter using the hashtag AskCOVIDExperts, and FHI 360 will answer your questions over the next week. My name is Dr. Otto Chabikuli, Director of the Global Health Population and Nutrition Business Unit at FHI 360. And I'm here with two prize guests, Dr. Doris Macharia, joining me from Pretoria, South Africa. Doris, how's life today?
Hi, Otto, and thank you so much. Looking forward to this discussion and really looking forward to sharing a lot of our experiences so far. Thank you.
We are still trying to get connection to Dr. Alex Coutinho, who will be joining us from Kampala, Uganda, and I will introduce Dr. Alex Coutinho as soon as he joins us. So Dr. Doris Macharia leads FHI 360 work in East and Southern Africa. She has over 15 years of medical, public health, and development experience in the region with significant first-hand knowledge of health and HIV programs in Africa. Doris, in the course of your work, you have interacted with all stakeholders from vulnerable populations like female sex workers to ministers of health. In a few words, how has that impacted you personally and professionally?
Thank you so much, Otto, and it's a real pleasure to be here. I think I must say that it's really been a privilege over the last many years. I always say I started off as a clinician, but the truth is I'm still a clinician in many ways. Working with different populations from this, from my time in Kenya at home, working in urban slums in Nairobi, to now being able to support and work together with a variety of many project leaders and staff members and communities in East and Southern Africa. So it's made me empathetic in terms of the situations we work in, but also very proud of some of the successes we've been able to achieve, especially in some of the programs that we've been working in, whether it be HIV, maternal neonatal child health, family planning, a whole range of really exciting work. But, there's still a lot to be done, but I think we also have to look back, and in my own career, looking back and seeing, the fact that we've been able to move and walk this path with a number of really fantastic people who've really changed a lot of the trajectories in terms of HIV and TB and many other infectious diseases in Africa. Yeah, thank you.
Thank you for that summary, Doris. Really rich experience. Just a reminder to the audience that we're still trying to connect to Dr. Alex Coutinho in Kampala, Uganda. He will be joining us shortly. I have so many questions for you, Doris, and when Alex will come, we'll continue the conversation with him. But let's start with some big picture. Then we will go to specific responses like the ones in South Africa and in Uganda. The question we're looking at today is really, does science guide decisions on which physical distancing approaches countries are adopting now to lift the lockdown? Where is the role of science? That is really the big question. Do you have a comment to say about that?
Certainly, and I see Alex has come in.
Oh,
Alex.
Haven't seen him. Let me just
check. Hi,
check.
Otto. Hi, Doris. Apologies.
No.
Good morning, Alex. Good afternoon, your side. Good to see you.
Thank you. Sorry, some connectivity issues.
Right. So maybe, Doris, before we go further, let me just welcome Alex. Alex, thank you for joining us today. Dr. Coutinho is a global health leader, over 35 years of public health experience. He's a senior lecturer at the University of Global Health Equity in Rwanda. Most recently, he was executive director for Partners in Health in Rwanda. And before that, Alex chaired the board of the International AIDS Vaccines Initiative and the International Partnerships for Microbicides. Dr. Coutinho also led the Infectious Diseases Institute at Makerere University in Kampala, Uganda. Alex, I believe there are two career-defining phases in your path, being at the coalface with TASO in the early 2000s and accepting the Hideo Noguchi Africa Prize in 2013, right? Do you want to tell us a little bit more how life was at the time?
Well, I've been in infectious diseases and public health for a very long time, but you know, my progress or successes are really defined by the teams that I worked with, and I was privileged to have really good teams and to be at the right place at the right time, both in responding to the HIV epidemic, and now, of course, here we are with this COVID epidemic. But thank you for inviting me to give my thoughts today.
Thank you and welcome again, Alex. And let's then go back to the first question as we started the conversation. Contrary to the predictions of an exponential increase in new cases of COVID-19 in Africa, both Uganda and South Africa have done a great job of containing the epidemic in this early phase through strict physical distancing measures that we, generally are known as lockdowns. How did that happen? What role did science play in this early phase as you observed the lockdown being applied? Let's start with you, Alex. Tell us about the experience of Uganda.
Well, Uganda locked down very early. It locked down before we actually had the first case of COVID. I think we locked down 3 days before that. And so, consequently, the next 11 weeks, because it's been 11 weeks since we locked down, we've only had 500 cases, which is really small compared to, what we've seen happening in the United States or Brazil or Europe. And what was key was that very early lockdown. And I think behind that very early lockdown is the fact that Uganda has had experience with Ebola several times. So the Minister of Health, the public, and the president were well aware that this could be a disease that's very similar to Ebola in terms of its infectiousness. And so were very decisive. And as you can see, the slide, it's showing that, from lockdown, which happened around March the 18th, we've been going at a flattened curve. You have that interesting little spike on the right where the cases go up and then come down. That's because the case numbers were adjusted to exclude anybody who had tested at the border but had not been allowed into the country. And then we see a more recent spike in the last 2 weeks, which is really driven by truck drivers. So the epidemic, the COVID-19 epidemic in Uganda has really had 3 main groups. In the early phases of the epidemic, in the first 4 weeks, we had people returning from Dubai, from the United States, from Europe, and those were about 55 who tested positive. And then we had a few contacts of those who tested positive. But our epidemic in Uganda, especially most recently, has been driven by truck drivers coming in from Tanzania, coming in from Kenya, coming in from South Sudan. And I think what the Uganda government did right was it understood that if the first cases had come in through the airport, then the next cases were probably going to come in through the land borders because we had no more flights. And so there was proactive testing and
we seem to have lost audio. Alex, can you hear us? Hello, Alex, can you hear us? All right, while we're waiting for Alex to reconnect, I'm sorry about the technical glitches. Doris, do you want to share your experience with South Africa? Is he back?
Yeah, Doris, go ahead. Let me sort out my connectivity issues here.
Sorry.
Yeah,
sorry about that, Alex.
This is Africa, you know. Yeah, but I think good question, Otto, and I think certainly, I think before even talking about the actual, strategies that the South Africa put in place, I think it's important to really think about and understand the context. First and foremost, South Africa has a very high proportion of population that doesn't have any health insurance, about 80%. We have a national health insurance that unfortunately is not yet, has not been implemented, but is going to be implemented. Our hospital bed capacity is about 2.8 beds per 1,000 population, which is obviously much lower when you look at Europe, US, and other, OECD countries, but certainly higher than many other sub-Saharan countries. We have 7,000 critical care beds, and of these, it's estimated about 3,000 of these would be available for COVID. And even though South Africa has a very impressive HIV and TB program that it's implemented, there's been zero experience in managing outbreaks like SARS and MERS. So that's the background. And then here comes COVID-19. And just looking at the slide that will come up shortly, we had our first case confirmed on the 5th of March. And this was from a traveler who had arrived from Italy. And 11th of March, if many of you remember, WHO declared COVID-19 a pandemic. And 4 days later, the South African government invoked Section 3 of the 2002 Disaster Management Act and actually declared a national state of disaster. So that was a good thing. Yeah. But just as Alex has said, in a bid to reduce these new cases that are coming from travelers who were exposed or infected, a travel ban was instituted on the 18th of March. And by then there were, about 116 cases. So think about that. Within 13 days, you have over 100 cases. So this meant that the South African government needed to act very quickly. President Cyril Ramaphosa, went ahead and declared a national lockdown, which started on the 27th of March. We like to call it a hard lockdown because there's no movement, only for essential services such as medical care, financial services, and those who are listed as essential workers. And by that time, 27th March, which was literally, I think, about 22 days from the first case, we had actually breached the 1,000 mark, and community transmission was already very evident. So what essentially the government had to do, they had to think, how are we able to get ahead of this situation? So enforce physical distancing by ensuring a lockdown was in place as they began to prepare the healthcare system. And how they went about this was making sure that we had more beds, up to 20,000 beds were going to be made available, new hospital beds, as well as 27 field hospitals. The government was quite ambitious. They declared and commissioned a national ventilator project, which is actually spearheaded by the big arms dealer. So, you think about it, arms dealer, the producer and of electricity, they went ahead and put this sort of project together with an aim of ensuring that we have 10,000 new ventilators available by the end of June. And on the 1st of April, the Minister of Health really deployed quite a number of community health workers and mobile testing to really ensure that mass screening and testing takes place. However, inevitably, as we've come to learn, not only in South Africa, in other countries, the more you test, the more other nightmares start. Right. So we tested more, but at the same time, our new cases went up. And what essentially happened is that the extension was extended to the end of April. And the 1st of May, we received some really welcome news. The lockdown was eased, but as you can see from this graph, it was eased, but guess what? The cases are going up. And because of various unease, which we'll talk about in a short while, we moved into, lockdown was eased again on the 1st of June, which was just a few days ago. But look at where we are. Over 760,000 tests, which is really commendable. More than 35,000 cases total confirmed, and over 700 deaths, which is a fatality rate of about 2%. Definitely better than the global estimates. But what we can see here is that we have the exponential. So what what essentially we were thinking we're trying to avoid actually has come to play. So we have to rethink what was the lockdown all about? And this is, we'll discuss this in more depth. But I think more interestingly, as we can see here, the active cases are actually, the recoveries are surpassing the active cases. And I think that is the good news that, South Africa, and I think from my side, that would be important to continue sharing, that, you can recover, and it's not just about all doom and gloom. However, we needed to take some action. Yeah, perhaps over to Alex.
No, thank you very much, Doris. And it seems like from your description that it has been really well planned in advance, and there were a lot of calculation, evidence-guided decisions that were made, and investment were guided as well by the planning related to the number of beds and potential. So tell us a little bit about the advisory team that was behind some of the measures that were put together. Yeah. I'm just trying to come back to the role of science.
Absolutely. There is a command council. There's also an advisory team that advises of course, the minister, and of course, by the president. And this really is, has various people from, very well-known, well-published researchers in South Africa. And I think what has really been admirable was the fact that the development and consultative process of having a risk adjustment strategy. Because initially government came under a lot of criticism. It looked like, as we say here in South Africa, Alex, thumbsuck, like, are you thumbsucking this lockdown? The answer is no. They needed to put together a risk adjustment strategy that looked at aspects beyond just health, looked at economy, looked at the education sector, unemployment, and of course ensuring that the government eventually at the end of the day was able to have a stimulus package, because if we were going to be in this national lockdown, no one is working, it was going to be detrimental. So that advisory committee and team, mainly made up of scientists, epidemiologists, and so on and so forth, were really at the forefront of really advising government what action needed to be taken. I think the other thing, if I can say so, having a minister who is a clinician perhaps helps. In many ways, because, the understanding and the articulation of being able to really understand the epidemic, I think enabled South Africa to be a little bit ahead of the game. But obviously there are some pitfalls here, which we will come to in a short while.
Yeah. Now, so definitely there was a very good sound amount of evidence that were fed to the government, and government was receptive to it in the early phases. Absolutely. Let us go back to Uganda. Alex, if you're with us, can you pick up the story from where you left?
Yeah, so Uganda had learned from the Ebola epidemic. It had learned how to do contact tracing. It had learned how to follow not just the primary contacts, but also the secondary contacts. And so applying these lessons and activating teams of healthcare workers who had already done this work, they already had experience, meant that it was much easier to scale up contact tracing, quarantining, isolating, so that each index case did not result into multiple other cases of COVID-19. And I would put that as an important success factor, that Uganda was not starting from scratch. It was starting from experience of another disease, unlike many other countries that may not have had that experience. In fact, it already had screening for temperature at airports long before many other countries. Kenya also had screening at the airport long before other countries, and some of the first cases were picked up at those screening points at the airport. But leadership has also been very key, and in particular, there is a national task force, but there is almost a weekly, how shall we call it, briefing from the head of state, and trust has been built with the community. You cannot tackle COVID-19 to either implement a proper lockdown or lift a lockdown scientifically if you don't build that community trust that what you're being asked to do, which is often very difficult and may affect you personally and your family. And so creating that trust, and in fact, if you look globally at some of the countries that have not worked that well, because we have to learn from those countries that have worked well and those that have not worked that well. many of them have these trust issues with their leadership, and we'll get to that. So I think these were success factors. We don't have any significant community spread. We have an epidemic that can be defined as hotspots so far, with the main hotspot right now being truck drivers and their contacts. But if we had not implemented measures very early on, we would probably have a wider spread epidemic than we currently have.
And just to clarify, Alex, the think tank is the one that you're chairing, right?
No. Mine is very different. The other is a national task force that makes decisions. The think tank is more global, that I'm looking at in terms of learning lessons from other countries and how do you apply them, not just to Uganda, but across Africa.
Oh, okay. And that task force, what is the composition in Uganda in terms of public health experts versus non-public health expertise?
This is for the national task force?
For the national task force, yes.
So its composition is first Minister of Health, the School of Public Health at the main university, but also a multi-sectoral representation, particularly from security, from Minister of Transport, given that a lot of our cases are coming from truck drivers, and a number of other ministries that come together to implement the task force.
Okay. Oh, thank you both for that. Now, it seems at this point in time that the well-established public health approaches that have been guiding the institution of the lockdown in the early phases, where everybody was in agreement, there seems to be a little bit of contestation happening. A few days ago, for example, a senior WHO director, Hans Kluge, warned as follows: the second wave is not inevitable, but an increasing number of nations are lifting restrictions, and there is a definite threat of a repeat outbreak of the COVID-19 infection. He goes on to say a second wave may be very destructive. If we take as well Lawrence Summers, former US Treasury Secretary, statement that lifting lockdown in the US is pursuing a strategy of hope and prayers, not a strategy with a rational foundation. And we go closer to home, renowned scientist in South Africa, Professor Glenda Gray, is on record. She's the head of the MRC in South Africa. She's on record castigating that the gradual phasing out of the lockdown has no scientific basis. So while there was this agreement of the scientific community around institution of the lockdown as a measure of physical distancing, on lifting the lockdown, there are now these voices coming out from WHO, from people from Treasury looking at economy, and scientists in the health sector saying things are not happening according to the way science would otherwise dictate it. So the issue at hand is this, the social and economic pressure on one hand, and health imperatives or public health imperatives on the other. Now, how should policymakers balance this data point emanating from these three sectors, which is the social sector, the economy sector, and the public health sector? What are you observing, and what would be your thoughts around that? Let's start with Alex.
Otto, we need to go back a little bit to understand why did we lock down, because we are trying to lift lockdown. So why did we lock down? And mark my words, locking down in whatever version, some countries lock down what is called light lockdown, and some, like South Africa, had a really tough lockdown. Yeah. But regardless, each country locked down. There's no uniformity in that lockdown. I have a little list here, if you don't mind me reading it. We locked down to prevent importation of cases of COVID-19. In fact, there must be only 1 or 2 countries in the world that have managed to lock down and no single case entered their territory. I think even Lesotho now finally has 1 case. The second was to prevent spread of cases of COVID-19. In other words, to flatten the curve and make sure that you don't have as many cases. In fact, Mauritius, their lockdown was so tough, and because they are an island, they've virtually, and New Zealand have virtually halted new cases of COVID-19, but that's quite rare. But many countries have managed to prevent spread. The third reason to lock down was to build awareness of a new disease in a population that knew nothing about this disease. And so hopefully get the population to understand how to prevent it. The fourth was to build awareness of the signs and symptoms of this disease, and so that the population knows what to do if they get sick and where do they go. The fifth is to start testing programs. You know, it took a while to be able to test for antigen and test for antibodies. And of course, the sixth is to build the capacity of health systems to be able to absorb both symptomatic and asymptomatic cases. The seventh is what I've already talked about in terms of establishing contact tracing and isolation and quarantine. And finally, to identify where the new cases are coming from. What are the hotspots and what are the vulnerable populations? These are, give or take one or two, about the same across the whole world. That's why different countries have chosen to lock down in various scenarios. South Africa, you know, took the unusual step to ban alcohol because it has a history with alcohol, and it felt at that time that you needed to empty the wards of alcohol-related cases. They also banned smoking, which made sense, I suppose, if you consider this a respiratory disease. But I'm sure Doris will talk about the backlash that came from that version of a lockdown. So if we understand that, and we're now faced with lifting a lockdown, we have to understand what lens are we using. If we use a COVID-19 lens only and say, if we lift lockdown, we are going to get more cases of COVID, then that's right. And so many countries will say, we don't want COVID, we are going to lock down until we get a vaccine. And there's no country in this world that's going to lock down for 1 year. It's impossible. So we need several lenses to evaluate how we lift lockdown and how much of lockdown do we lift, because there's no country lifting lockdown back to business as usual 1 year ago. Each country is doing it differently, but we are not going to back to business as usual until we get a vaccine. And so you have to use a second lens within the health sector, that if COVID is causing death, are there other health conditions as a result of a lockdown that are going up? And experience with the Ebola epidemic and experience coming from other countries is saying vaccine preventable diseases are going to be on the rise because vaccination rates have gone down. Maternal and child health conditions are already probably causing additional deaths. Non-communicable diseases, HIV, TB, mental health, you name it. So it's not fair for someone to say, and it's not even fair for WHO to say so if they also don't use this other lens and say, you have to do a risk-benefit analysis. The other lens is, of course, the economy. And a good economy that is used for the population is a good public health intervention. If countries like Uganda or South Africa or Kenya find themselves with no revenue, not enough revenue from the economy through tax collection or whatever, and at the same time, traditional donors are not going to give us their money because they are struggling with their own COVID epidemics, then we are going to have a major public health crisis caused by a collapse of economy. So you have to use that lens as well. And then you have to use the lens of the social and mental well-being of the population, because controlling COVID can only work if the population cooperate. There is no authoritarian regime that can use guns and sticks to beat the people to adhere to, how do you call it, to the guidelines. The population in turn needs to cooperate, and there is a limit in terms of weeks or in terms of months that a society is going to accept to be totally locked down. So if you use all of those lenses, then you reach a point where you say, you know what, we locked down in order to control but not eliminate COVID. Have we reached a point where we are comfortable to the degree that we have controlled it, that the threat from COVID is counterbalanced by now a new threat of prolonged lockdown or prolonged economic decline? And what is the risk-benefit analysis that we can use? There is no perfect science for this one, Otto. Let me preempt your question. There is no perfect science because you have an intersection of biomedical science,
right,
with social science, with economic science, with political science, because in the end, the decisions are going to be made by politicians. And when you mesh those, I don't know what name you're going to give that type of science, but perhaps Doris might want to comment because she's seeing this in action in South Africa.
No, absolutely. So Doris, over to you. I know South Africa, there's a history of activism, both at public health level, but even scientifically, people are very, very vocal and engaged. And it is really happening right now. And as Alex says, it is not lockdown or nothing. There has to be something in between. And how is that being negotiated in South Africa right now?
Yeah, thank you, Otto. And thanks so much, Alex. I mean, I wish I had all these answers, right? I think the first thing is, maybe we've been saying, we cannot lock down forever. I think that's the first point. And I think we've all sort of agreed that it's not going to be possible. Of course, the issue is how long and for, how restrictive should we have our lockdowns. The second thing is also around the fact that we have to live with COVID. I mean, even in various, whether it is family and other social circles, everyone is talking about living with COVID in one way or the other. I think if we look at, let's say, the South African government, one of the things over and above preparing the health system and the testing and the tracing and isolating was, we here in South Africa, it's just like in a number of other countries, have a big problem with seasonal influenza. So one of the positive things, as economists say, positive externality, meaning, an unintended benefit, right? Our seasonal flu has been delayed. This is a good thing, right? So I think in looking at lockdowns, we also have to look at how have we also coped and what do we need to do differently, right? And, the fact that we don't have seasonal flu, it has, it has decreased the stress for, health services and obviously provided an opportunity for more, COVID, those who are infected to get services. I think the other thing for me is behavior change is possible. It is. Right now, if you go out, if I get out of my house here, people will be wearing masks and sanitizing, almost spraying themselves with 70% alcohol-based sanitizers of sorts. Behavior change is possible, good news. However, as Alex has said, we have unintended consequences because again, when we started the lockdown, probably we didn't think through everything, right? Hunger and despair, rising unemployment, mental anguish, and of course, the cigarette and alcohol ban. That's been a real pain here. But I think, unfortunately, it has really distracted to the real objectives of the alcohol and cigarette ban. We've seen lots of distressing in the media in terms of electronic and print media, in terms of how people are celebrating now that the alcohol ban is no longer there, and just literally the next day the bed occupancy in some of the hospitals here went up immediately. Alcohol related trauma, alcohol related, what have you. So that tells you the real issues here. However, I think the fact that one can have a risk adjustment strategy that looks at all these sectors, not just health. Yes, science must guide. Science must provide advice. However, the decisions is also making sure that how does that particular advice and guidance play to the education sector, the economic sector? Do I wear open shoes or closed shoes? It literally is those sort of details. But I think in looking at what works well, and just picking back from what Alex was saying is, what is the best type of lockdown? If you look at South Korea, no lockdown at all. But guess what? One thing is lost on people, their culture of, they have a culture of respect and voluntary cooperation. So things could work there. Two, they have a universal health coverage. So anyone can get healthcare anytime they need without any out-of-pocket expenses. That is a plus. Two is that they learned a lot from their MERS experience in 2015. They really bungled that one really badly, and they knew what to do differently. So in this case, they didn't need to have a lockdown, and it worked. Now, turn the case around. Sweden tries to use the same sort of idea of we're not going to have a lockdown, we're going to have voluntary cooperation, and we're going to go for herd immunity. And just a couple of days ago, the chief epidemiologist had to concede too many deaths. We could have done this better. They have 50 to 100 times more deaths than their neighboring countries, Finland, Denmark, and Norway. Now, if we come back to the African context. I think what has worked well and what's showing some promise, I think back to what Alex was saying, is the partial lockdowns. And I'm just thinking about, you know, countries like Ghana and Kenya, and of course Uganda and others, but just those two as an example. Look at Ghana. Ghana decided to just lock down places like Accra and Kumasi. They ramped up their testing, you know, to about 200 or, you know, 200 plus thousand. And yes, they have 800, I think about 8,000 cases, and their death rate started going down. And just a few days ago, they eased their lockdown. Again, targeted hotspot, you know, looking at their hotspot and doing lockdowns and continuing with the individual prevention measures. I think that has worked well. So one place you are locking down specific areas, but the economy is continuing. You know, the healthcare system is also being prepared in the best way possible. So I think it is figuring out what is the best middle ground. And at the end of the day, you know, when you read these articles and they talk of draconian measures, you know, which are taken, there's no, you know, we all make mistakes. Hindsight is 20/20 vision, no doubt about it. And, you know, I'm even reminded, I come from Kenya, and, you know, we have a saying, a Swahili saying, that says, fuata nyuki, ule asali. If you follow the bee, you will eat the honey. So if you follow the evidence and if you follow the science, you'll certainly get somewhere. So it's not to lose track of that, but to remember that the voice of the citizens is important, the voice of the economic sector, and also other health and medical sectors are also just as important. Yeah.
I will start looking for bees around here,
yes,
and keep following them, and maybe I'll end up with some honey. But you both just raised a couple of good additional thoughts in my head. You spoke about behavior change. You spoke about local culture and staying in tune on there are things that are possible and others that are not possible. You spoke about political will. And I was looking, I mean, the advantage that low and middle income countries have is that the epidemic came, we got months behind other countries. So we have a lot of lessons. You just mentioned Sweden. But we see some countries also trying, because there are so many unknowns and this is new and there is no straight answer. It is a very difficult moment for policymakers on the continent. It seems like they have to be more of artists than hardcore scientists, without losing the science piece, of course, but balancing it with so many other things. If you were an advisor, what kind of framework would you put in place to advise your local government? Because we see places where there's some denialism happening, like in Tanzania. In Brazil, there was also denialism happening at the highest level, and the consequences are really, really bad. So how should we advise policymakers to approach this? How would you do it, Alex?
Yeah, well, thank God I'm not one of those, because it's a very difficult decision. It really is. Whichever decision you make, it's possible that some people are going to die. And we need to respect the people who have the responsibility to make these decisions right now and do the best that we can help them. And you're right, some of it is science. Some of it is going to be experience and wisdom that comes from, and some of it might even be guesswork. But some of it also has to come from learning from other countries who seem to have both got the lockdown right and also seem to be getting the lifting of the lockdown right. There are two countries I was reading about that haven't made the news as much, but I would urge those on the call to go check them out. One is Turkey. Turkey at one stage had an epidemic that was accelerating, and there were worries it was going to mirror Italy. That didn't happen. But again, they had experience of epidemics, and they did very, very widespread contact tracing and quarantine, and now to the point where they're reopening the economy. So that's a country that would be interesting to look at. The other is Vietnam. Vietnam, despite having a long border with China, has never had more than 1,000 cases and very few deaths. Again, very early interventions and a very good trust within the population to follow the public health guidelines that government was giving, both for lockdown and for lifting up the lockdown. If you contrast that with Brazil, and may I say the United States, there are also lessons to learn from several mistakes that have taken place in those countries. So the first advice I would give policymakers is learn from other countries. Have a think tank that's looking at what has worked, what's not worked, and understand your context, because each country has got its own context, and nothing is going to work perfectly in Kenya that's been imported from South Africa or Uganda or vice versa. So that would be the first. But there are other things that, I mean, there's other evidence that we know now that can be used to, even as you lift the lockdown, to reduce the spread of COVID-19. Science, that's the science you want. We know that it's a respiratory virus. We know it's transmitted by aerosols and droplets. And we know now that face masks have a role to play. They are not 100%, but they have a role to play. Unfortunately, there have been confusing messages coming from, even WHO, and the population are saying, do they really work or don't they work? Confusion between healthcare workers who use a face mask to prevent getting the infection, vis-a-vis the public who wear a face mask so that if they have a cough or they're asymptomatic, they are not putting that infection out into the atmosphere. So this is something we would need to clean up and make sure that the population understands that when you use a general mask, you need to use it collectively so that you protect each other. The second piece of evidence is that this virus, its transmissibility is increased within a contained space. So indoors, you have far more efficient transmission than outdoors. There's evidence for this. So maybe we need to start thinking of what are all the things that we can do outdoors instead of doing them indoors. If you take it to an extreme, Otto, maybe we need to restart schools the old way in Africa, under mango trees, out in the open, so that the virus, if it is there in school children, is dispersed by the wind and diluted by the atmosphere. Now, this might sound crazy and I have no evidence, but we need to rethink the way we're doing things. We are not going to get populations and put them back. Maybe we open restaurants, we close the streets in the evening so that the evening, the restaurants can move in the streets and be outdoors rather than indoors, because the evidence for that is very clear. The other evidence is that this thing is going to be with us for a year at least, and for Africa probably longer. Just because there will be a vaccine, if there is a vaccine in the United States in January 2021, does not guarantee that that vaccine will be in Kampala or Johannesburg or Juba in January of 2021. And so when we start advising policymakers as to what they need to do, they need to understand that this is going to be for the long haul. This is not, the decisions can't just be for short haul. And there are things that you may not be able to advise them what to do. Frankly, I don't know how we can get schools back safely unless maybe we put them under a mango tree. And even then I have no evidence. So there are things that are very difficult. How do you get people to go to church or to the mosque safely? Maybe you put them in a football stadium so that, you have, but at the same time in Uganda, church service through television seems, and even mosque service through television seems to have been accepted for the time being. How long that will last, I don't know. The other final policy advice, and I'll let Doris come in, is that we know that there are some vulnerable populations. We know that the elderly above 60 are more vulnerable. We know underlying conditions like diabetes and hypertension and cardiac disease are more vulnerable. So we need to identify these vulnerable groups. We need to be testing not just for COVID, but we need to be testing for diabetes and hypertension in the community so that we can identify these vulnerable groups and perhaps have a voluntary tighter lockdown for these vulnerable groups so that they are not as exposed to COVID, because if they do get it, they may have much more serious disease rather than younger populations that have no underlying conditions. I'll stop there for the time being.
No, thank you so much for that, Alex. Doris, it seems like we agree, we are landing to a point where we agree that physical distancing still has to go to be there, but it has to be socially and economically sensitive. And Alex has just elaborated a few, and it seems to me that the communication between policymakers and the community and the individuals becomes paramount. Policymakers need to know their people. People need to understand and trust what policymakers are putting in place, that it is to their benefits. From a South African perspective, understanding that context of South Africa and maybe Kenya or Uganda, Nigeria, how do you see that link, that connectivity? What's the best way of establishing that link?
That's a tough one, Otto. I mean, most of us come from communities and countries where there's a definite mistrust for any politician, except, you know, we always see them coming around when it's time for voting, right? We get the new T-shirts and we get a bag of maize meal, or what we call here mealie meal. And there's that sort of always mistrust, always, you know, back and forth. Huh? So now here you have this particular pandemic, which, you know, you have to message this correctly. And as Alex has so well put it, is making sure that the messages are obviously clear, concise, and obviously are disseminated properly. And that's where the problem is. It can't be with this wishy-washy, you know. And for me, I would say, don't stress the small stuff, right? Don't stress the alcohol ban, you know. Don't stress the shoes which are open, because that's the small stuff. Think of the bigger picture. What do you want people to do? There's a behavior change, right? There's also the testing of other comorbidities, as Alex has just said. That's the priority. So you need to prioritize bigger picture here. People understand that. I think where it has been difficult here in South Africa, because, you know, there's always a mistrust, unfortunately, you know, and right now we are sitting with, I believe the High Court, the Gauteng High Court actually made the, you know, the level 4 regulations of easing are irrational. That was the word that was used. And that was unbelievable. And the next headline was, yeah, this is why we need to take government to task. It just shows you, you know, that if you sweat the small stuff, when I say small in the sense that it might not be a big priority for that person, you know, what do we want to communicate? COVID can kill you. However, we have a test here is available. These are the things you must do. Now it becomes an issue of, can I drink alcohol? Why am I not smoking? And, you know, and you lose the whole agenda. So keep it very precise, keep the communication very clear, continue making sure that people also understand, you know, as you're communicating in their own languages and the way they understand their messages, right? Because even with masks, we've seen people I think in Kenya and other countries, I saw, you know, people were going to pubs, right? And they're wearing masks. So someone puts down the mask and you're still in the, you know, in the pub and it's closed and you drink and you put back your mask on. So is that the right behavior? No. So has it been transmitted in the right way? So for me, it is those kind of things. Is of, don't stress the small stuff. Think of the bigger picture, be clear, and make sure that you're able to communicate in the language people understand most, and ensure that, you know, at the end of the day, people will lose jobs, and unfortunately some of their relatives will die. And I think one thing that has been very difficult for many people is the, you know, dying alone, right? Even for those who don't have COVID are also dying alone, because who is going to be there to hold your hand and be able to say a prayer with you? So those sort of things, and being government and the advisors around, being very, very empathetic to those realities that we each live, I think is going to be really paramount, so that we, is what we usually say. I think Americans say the big wave, you know, the sail, the boat carries everyone. So that's what we want. We want this message to carry everyone, that big wave. I could tell you in Kiswahili, but I think I'll probably get a bit tongue-tied. But, you know, the message is there. You know, you need those big waves that are able to carry everybody. And you need the leadership, but you need the science to be able to guide and direct and ensure that it doesn't trump everything, but it must guide. And you must make sure that you hear the voices of the people, because in any case, that's who is being led. Yep.
Yeah, no, thank you so much, both. I mean, unfortunately, time is against us, but I have a lot of hope, because we have
about one issue that policymakers need to think about. I'll take 20 seconds.
Go ahead, Alex.
A key issue in controlling epidemics, not just here in Uganda, but Kenya to some extent, I don't know about South Africa, but definitely in Japan and Vietnam, has been contact tracing and quarantining anyone who tests positive, whether they are symptomatic or asymptomatic, and not quarantining them in their own home, taking them to a government designated quarantine area. Now, it's been tricky because people have seen quarantine as a punishment. But governments have seen it as an effective strategy because it takes the person away. And many people who are voluntarily quarantining actually were breaking their voluntary quarantine. Now, when the number of cases is 500, that's easier to do. When it hits 35,000 and their contacts are 100,000, you have to find another strategy other than forced quarantine in a government facility, because that may distract from other messages. I just wanted to put it out there. You can use it in the early stages of the epidemic. It's unlikely you can use it much later on when you've got a much bigger epidemic.
No, thank you for that addition, Alex. I carry a lot of hope because we managed through the HIV epidemic to translate very complex scientific evidence into languages that communities could understand. We managed through the fight against HIV to find alternatives ways of getting to the homes and the communities and getting advocates alongside us to understand the experience and build empathy in the policies and responses, including human rights and gender-based violence and so on. So I think leveraging from all those experiences of the past, we stand a good chance of chartering the troubled waters of COVID-19 ahead of us. This has been one of the most pleasant conversations. Thank you very much both for being generous in sharing your thoughts, observations, and experience. It is a serious issue for the humanity that we are dealing with. Countries all over the world are lifting the lockdowns in many, while even the number of cases are increasing. Flattening the curve is still possible, provided that locally generated, locally relevant data are used to guide policy and practice. Please look up the recently issued guidance on lifting lockdowns that Africa CDC has just issued. It is available on their website. A very good document, well elaborated, and I think every policymaker should have a look at it before guiding government. Just a reminder, Alex is a senior lecturer at the University of Global Health Equity in Rwanda, and Doris is director of the SARO office for FHI 360. Alex and Doris, thanks for joining me today. I wish you and all your co-workers good tidings.
And you too. Thank you so much. And thanks, Alex. Pleasure.
If you have questions for the panel about today's discussion, please contact us on Twitter using the hashtag @AskCovidExpert, and FHI 360 will answer your questions over the next week. Until then, goodbye.
Thanks, Otto. Thanks, Doris.
Thanks, Alex.
Asante. Yes, thanks.